And now I'm requesting Professor Chen. After that, we should go for a vigorous discussion, as because this is the main part of our discussion. And one thing I can just keep you in your want address you to keep in your mind to stimulate yourself for the next talk. Actually, EVC main published recently, and DK Crash trial is done by Liang Chen, and definition true trial also run by him. He is the main principal investigator. And after that, we go for question answer session and discussion. So Professor Liang Chen, I am requesting. He is the inventor of DK Crush technique, and he is the principal investigator of DK Crush 3 and DK Crush 5 trial, as well as definition true trial. And he nicely defined the complexity of the lesion by definition true trial. So I'm requesting Dr. Shaoliang Chen, please.
Oh, thank you. Can you see my slide?
Sure.
Yeah, thank you. Thank you for inviting me to be part of your meeting. Even one stand and two-stent technique, the battle is a very ancient topic, but I think this topic is still very attractive because so far there are many arguments about the selection of different stand strategy. Today I'm very excited to see all my friends, particularly Imad and Myra Slow, on screen. Thanks for your very excellent presentation. So let me go through my summary of the current guidelines from 2018 ESC guideline on myocardial revascularization. From the guideline, you can see the first statement is prominent stenting technique should be the preferred approach for most bifurcation lesions. I think this is the general summary, general guideline for all our intervention cardiologists. But the exception to this rule include large side branch if side branch diameter minimal 2.75, side branch lesion length longer than 5 mm, or anticipated difficulty in accessing an important side branch after main vessel stenting. So just based on these three elements from the guideline, so far I think I do believe these three conclusions are only depending on the very small clinical study. So far no colleagues agree with the side branch diameter 2.75 or side branch lesion length longer than 5 mm are two cutoff for the prediction of clinical outcome. Just after presentation by Imad, so one Bangladesh colleague asked why side branch lesion length cutoff value is 10 mm, why not 16 or even 20 mm? Because this is derived cutoff by statistical regression from our definition 1 trial, including more than 3,660 patients with true coronary bifurcation lesion. Finally, the guidelines say true distal left main bifurcation lesion could be the indication of upfront side branch stenting technique. It means two-stent technique could be used for large side branch, long side branch lesion, or difficulty to access side branch after main vessel stenting, or finally for true distal left main bifurcation lesion. So now we forget the argument about the exact definition, exact cutoff value, but the guideline provides the trend to recommend use of two-stent technique. Again, from the same guideline, so it provides the importance of bifurcation types. So from the table 6, from this guideline, you can see for Medina 111 or Medina 011, two kind of true coronary bifurcation lesion, we have two additional scores for the complexity of bifurcation lesion. Of course, from the table, we can conclude true coronary bifurcation lesion and bifurcation angle may correlate with clinical outcome. But for the preliminary conclusion, we had to do more clinical trial. So next, let's go through my very interesting case. This is very young patient, only 48. He had been working in foreign countries for many years. And from angiography, you can see. So I used the 6 French guiding from transfemoral approach, very diffuse lesion in RAD with very severe calcification from proximal to distal part. Also, from the left shot is epicranial. We cannot separate RAD diagonal very clearly. So when we move to aerocranial, you can see the angle and the orifice of diagonal looks very, very ambiguous. So we cannot make sure, we cannot guarantee the exact position of the osteodiagonal. So at the bottom from left to right, you can see we use the still image tried to very clearly separate the RD diagonal. So on the right panel, you can see finally we change to use 7 French guiding catheter. Basically, according to the angiography, we can conclude Medina 111 severe calcification in both main vessel and diagonal, side branch lesion length longer than 10 mm. Also very small reference vessel diameter in both main vessel and side branch. For this case, first of all, we could not advance or even 1.5 balloon to distal RID, so we perform a rotation osteotomy followed by check of IVUS. So from IVUS on the left, you can see, so the diagonal looks a very small vessel according to the angiography, but from IVUS you can see the real vessel diameter of proximal diagonal was around 3.25 millimeters. So it means a diagonal is not a small side branch. So this is a very important find to remind us in some cases, not in most cases, only according to the angiography, you could not access the real diameter of the side branch. So when we conclude any given side branch is a small vessel, we should be very cautious. Again, on the right, you can see the distal diagonal vessel reference diameter is also less than 3.1 millimeter. Again, from both LAD diagonal, you can see very long crina between LAD and diagonal. So this is very important anatomical features to indicate the acute occlusion of the side branch immediate after stenting LAD. So I think for this very complex bifurcation lesion, no doubt about the selection of two-stent technique. Here, I like to summarize the general finding from our DK question 2, 5, and 6 3 trial. So in these 3 trials, there were 702 lesions being treated using provisional stenting technique from intention. So I only provide 1 year follow-up, including cardiac death, target vessel myocardial infarction, TLR, and the primary endpoint tight lesion failure. Also, we compared the difference in terms of the stent thrombosis. So the table clearly shows over the increase of the side branch lesion length from 5 mm to 5 to 10 mm to longer than 10 mm. So all the events increased doubly, not only for cardiac death, but also for TLR and TF. I think this is a very important finding. Recently, we tried to write a manuscript to summarize this finding. So if we select side branch lesion length shorter than 10 mm, I think we could not get positive difference between systematic two-stent and provisional stent technique. Particularly recently, Julia published their meta-analysis to provide the real difference between a patient with short and long side branch lesion length. Again, let's back to the previous definition 1 study to derive the definition criteria. Similarly, for lateral and non-lateral bifurcation lesion is a side branch lesion length should be minimal 10 millimeters. So 1 major plus any 2 minor criteria. So the lesion could be defined as a complex bifurcation lesion. I do believe for most of distal left main true coronary bifurcation lesion, the side branch lesion length minimal 10 millimeters will be around 1/3, something like that. So recently, our Chinese colleague from Fuai Hospital just published their a single center finding to compare a provisional stenting technique and two-stent technique for definition criteria defined complex left main bifurcation lesion. From 1 year to 3 year follow-up, really there was a high rate of cardiac death and intelligent revascularization in a provisional group compared to systematic two-stent group. This is our subgroup analysis from DK-5. So here I don't think we have different result between DK-5 and EBC main, because on the left panel for the simple lesion group, there was also no difference in terms of the 1 year TF. Even this is a post-hoc subgroup analysis from DK-5, but it provides very strong chance to support the enhanced use of systematic two-stent technique for real complex bifurcation lesion defined by definition criteria. This is our final finding from our definition 2 trial, because we have very strong data to support the strong use of two-stent technique for complex bifurcation lesion. So in our definition 2 study, we only include a complex bifurcation lesion defined according to our definition criteria at 1 year follow-up. So higher rate TLR target vessel myocardial infarction after provisional stenting technique compared to DK-Quash group. Because in this study, in two-stent group, almost 80% of two-stent are a DK-Quash technique. So finally, there was a very, very significant difference in terms of the primary endpoint target lesion failure. It was 11.4% in provisional compared to only 6.1%. So if you still remember our findings from DK-Quash 3, 5, and also the result from BBK2, you can see the DK-Quash 10 really has very low rate of 1 year target lesion failure, around 5 to 6%. So final several slides, I like to share my latest version of animation to show us how to do DK-Quash technique. So after watching the animation, I like to highlight several very important steps. For example, so immediately after stenting side branch, so usually we can use a stent balloon to optimize the side stent. But for large side branch, particularly for sunflares, there are also some side branch taken from the sunflares. So the stent balloon is also still undersized for proximal side branch. We have to use another large non-compliant balloon to do a optimization for side stent. A second point is because the first balloon for crushing stent is undersized for the proximal vessel for man, so we had to use another large non-compliant balloon to further crush the side stent. Third point is we recommend always rewire to side branch from proximal to middle cell to avoid to rewire from the distal cell. I think these are only 3 key steps for DK crush. Even it looks like more steps than provisional, but I think the quality, the clinical outcome for patient is much more important than the difference in numbers of steps. So finally, take-home message here. So far, provisional stenting works well for simple bifurcation lesion. It takes account more than 70% of all bifurcation lesion, but systematic two-stent, particularly DK crush, is associated with lower rates of TLF at 1 to 3 years of follow-up for complex bifurcation lesion or distal left main true bifurcation lesion. Definition criteria used very friendly to identify a complex bifurcation lesion have been confirmed by meta-analysis, consecutive study, and randomized clinical trial. So don't worry, don't suspect the efficacy of definition criteria guided stenting bifurcation lesion procedure. Number 4 is a very, very important guidance by IWOS and OCT or even FFR. But finally, still there are 3 unknown issues. The first is provisional stenting does not mean one stent. It could be one stent and could be provisional with two stent. But in terms of the provisional with two stent technique, so far no data tell us about the real difference between provisional with T and provisional with TAP. Finally, is IWOS OCT or FF guidance superior to angiography? We are waiting for DK crush H and October trial in next year. So thanks for your attention. Thank you. I finished my presentation.
Thank you, Professor Shao Liang Chen.